Welcome back. Thank you guys for joining me this week. Just a reminder that the webinar, Navigating First Steps of Perimenopause, is going to be happening on Tuesday, May 28th at 7 p.m. Eastern. And if you are interested, I'm going to pop the waitlist link in the show notes. And now to today's special guest. I have on Dr. Dineasha Potter-McQuilkin, who's a highly accomplished, double board certified physician. She's also an esteemed OBGYN and a North American Menopause Society certified menopause practitioner with over 17 years of experience. Welcome, Dr. Dineasha.
Thanks so much for having me back. I'm so excited to do this today.
Well, we're excited to hear all your thoughts about hormone, actually not even HRT, more hormone therapy, because it's the new hottest thing. So My first question was, there's been a definite change in attitude about hormone therapy. And it feels like in the social media ecosystem, everyone from medical doctor influencers to whoever is on hormone therapy and talking about how good it is for us. So I wanted to know from you, outside of relieving symptoms for some women, what are the health benefits of hormone therapy?
That's certainly a great question. And yes, it's being talked about a lot, which is certainly great, something that we've been waiting for. I think a lot of influencers, doctors, women are seeing that a lot of the recommendations or the risks that we were informed about in the WHI study, some of them were overblown, right? So the risks were overestimated. So certainly kind of looking at all that data again and seeing where we are now and what's beneficial is great. But in terms of what the benefits are, you can have a decreased risk of heart disease, and that could be about almost up to 40%, which is certainly significant. Wow. Yeah, decreased risk of osteoporosis and fractures. It can help the elasticity in your skin. Certainly in terms of vaginal hormone therapy, decreased risk of those UTIs. So patients who've been having recurring urinary tract infections, which can certainly take you to the hospital. That's important as well. Estrogen and progesterone therapy can decrease your risk of colorectal cancer. There can be a decreased risk of hormone therapy of diabetes. So there are many aspects and many benefits, certainly. It would depend on the individual woman, the individual patient, to see what your risks are and certainly the benefits to you. But there are many, and that's probably why everyone's talking about it.
It is. And then this leads me to, I guess, the inspiration for you being on here. Yeah. One of my clients who's 54, she's still getting her period and in perimenopause, said, I don't think my symptoms are that bad, but now I feel FOMO. Like, should I be on hormone therapy even though I don't have any symptoms that might desperately call for it?
Yeah, and I could certainly see how she would feel that way if you're on TikTok or Instagram and everyone's on it, you feel and you hear about all the benefits. Am I missing out, right? Am I missing this benefit? And there is what's called a window of opportunity where the benefits greatly outweigh the risk for most women. So, I could certainly see how she may feel that way. But we have to understand that there are risks as well, right? As with many things, there are risks and benefits. And there are really only 4 FDA approved recommendations or for the hormone therapy, and that would be the moderate to severe vasomotor symptoms, that would be the genitourinary syndrome of menopause or vaginal atrophy, having what's called hypoestrogenism or having a decreased amount of estrogen due to if you had your ovaries removed, if your ovaries are no longer functioning due to chemotherapy, something like that, or if you have a very early or a premature menopause or what's called primary ovarian insufficiency. So certainly that's a reason that you can have it as well. Or for prevention. So not treatment, but for prevention of osteoporosis to decrease that fracture risk. So certainly if you're in one of those categories, it's FDA approved, that would be really an indication. But outside of that, it's very important to look and see your individual risks and see if in the benefits as well. So meeting with a hormone specialist or a menopause specialist to see what your risk and benefit profile are and to see if it's beneficial for you.
Oh, that's very helpful. I'm curious about what you said with the in terms of osteoporosis, osteopenia.
Yes.
So if someone, because I've seen this, like if someone has osteopenia, does it help? And you're doing all the other things, you're lifting weights, you're taking your calcium, vitamin D supplements. Yeah. Is that helpful in slowing the process, like osteopenia to osteoporosis?
Yes. So it can certainly help with that. It can help with that bone remodeling, because we certainly often we remodel that bone. So you can break down the bone and certainly build it up. So to decrease that bone breakdown, it can certainly help there. But you're very correct in what you said before. We kind of have to do the other things too, right? We can't just do that. But it is helpful in that. In healthy women who, if you don't have that osteoporosis already, because it's not for treatment but for prevention, in general, estrogen is much better at prevention than treatment.
Oh, I like that. Better at prevention than treatment.
Yeah.
And it goes on to the next question. I guess if someone's having FOMO and you're trying to figure out if it's for you with your menopause educated provider, who should not use it, or reasons why not to use hormone therapy? While I understand it's going to be very individual, but maybe general reasons.
Yeah. So yes, I think that's a great question, and certainly very important in this world now that we're seeing everybody's on it, right? So in terms of women who probably want to certainly take a deeper dive and see if it's really okay for them, it would be someone with an estrogen sensitive cancer. So if you have estrogen receptor positive breast cancer or progesterone receptor positive breast cancer, if you have an endometrial cancer, certainly if you're high risk for that, if you have undiagnosed vaginal or uterine bleeding, because that could certainly be an endometrial cancer that has not yet been diagnosed, right? So someone like that. If you're high risk for a heart attack, or if you recently had a heart attack or a stroke, because certainly it can aggravate those as well, especially if you do not use it transdermally, if you use it more orally as well, or if you have what's called a thromboembolic event, right? So if you have a deep vein thrombosis, that can certainly break off and go to your lungs, cause a pulmonary embolism, something like that. Those are patients which we really don't recommend that you use it. There additionally, gallbladder disease, because it can increase the risk of that. Or if you're taking it orally and you have really high triglycerides, then you kind of might want to work to get those down, before we certainly start it, especially if you're going to do, again, that oral route, right? So these are patients who should not take it, or if you're going to explore it, you certainly want to discuss, can I do maybe a different route? What's best for me? Should I be exploring, other options? I don't think a lot of these should be individualized, like you said, because it really depends on your individual case. But I think everyone deserves a conversation, at least to see, what their risks are and the benefits for them.
That's helpful to know. And in terms of hormone therapy, can you go into like what kinds are there? What exactly does that mean? Like there's estrogen, the progesterone, and then because sometimes I think there's one influencer who's like, oh, I always have the estrogen, but then I remembered my gynecologist said, no, you always do both for estrogen and progesterone for balance, and then and then testosterone. So like maybe go through that, the different ways of hormone therapy.
Yeah. So in terms of your sex hormones, you do have the estrogen, the progesterone, and the testosterone. And the progesterone, really, it's to oppose that estrogen. So we know that if you have what's called unopposed estrogen, so if you're taking the estrogen for the vasomotor symptoms, the hot flashes, the night sweats, you really want to take that progesterone if you have a uterus, because that will decrease your risk of that uterine cancer. So that's really where you see the benefits there. Now, is it really indicated if you don't have a uterus? A lot of studies are showing no, that you may not need it, but sometimes with my patients, I see that it really also helps with sleep. So even if they don't have a uterus, but they're really having that difficult time with sleep, they're kind of optimizing their sleep hygiene, it may be a time where we could certainly add that, at least for some time. In terms of the estrogen, that's really the main player, right? So that's really the biggest hormone. You have estrogen receptors all over your body. So that's why you can have an array of symptoms, more than 34, probably even up to about 50 symptoms, because there are estrogen receptors everywhere. So you can have that frozen shoulder. You can have the vasomotor symptoms like the hot flashes and the night sweats. You can have vaginal dryness. You could certainly have those urinary issues as well. So it's that's where the estrogen really comes into play. And so we will replace that to mitigate some of those symptoms. And in terms of the testosterone, the indications for that are really for a decreased libido or decreased desire. That's really where we would add that. We like to optimize the estrogen and the progesterone first, because if some of your decreased desire is because you're having vaginal dryness, and you certainly don't want to have intercourse with that vaginal dryness because it can hurt, and who wants to have intercourse when it hurts, right? So really optimizing that, and then adding the testosterone if your testosterone is low and the decreased desire is really there, especially with some distress. That's when we would kind of look at that and replace that as well.
Now, I know, like for testosterone, reading or seeing that there's the one that you apply to your skin versus, I guess, what's the other kind? The pellets? Is there?
Yes, yeah. So you can, so the transdermals are generally the one that you apply to the skin. That's usually in a cream. You can get pellets. I know some patients have done injections and things like that, but really the only one that's recommended by the Menopause Society, the one that's recommended by ISWISH or the International Society for the Study of Women's Sexual Health, that would be the cream. And I like the cream a little bit better because it's also easier to titrate or to change, right? So if you're taking a pellet, which can stay in place for 4 to 6 months, if we put that in and you have an adverse reaction to it, if you have what's called super physiologic levels where your testosterone goes super, super high, it's really difficult to change that, because once it's in, right? So there's not much that we can play around with there. Whereas when you have a cream, we can change that every day, right? So generally when I start the cream, you'll come back to me in 4 to 6 weeks. How are you doing? If you're not really seeing that much of a change, we can certainly check your levels and see if it's increasing. Then we may be able to bump it up. If you're getting too much, we can kind of back it down in terms of the dose, right? Because some of the side effects that you might see would be voice thickening, voice changes, voice deepening, and that could be permanent, right? That could certainly be permanent.
Wow, okay.
Yes, exactly. You could have clitoromegaly. So that's a very enlarged clitoris. So the function doesn't change. It's just extremely enlarged, and also some hair loss as well, right? So we want to decrease. We want to help with the desire, but not have any of these side effects. And you can get a lot of those when you do the injections or the pellets instead.
Oh, I see. So whereas the cream is a little bit, it's a little bit more, or a little bit gentler way to introduce it.
Exactly. We can change it, right? So with the cream, it's something that you would apply every day. So we can change it daily, right? Yeah, if you need to. Yeah.
Oh, so then you can kind of see if it's in your daily life, how it's affecting.
Exactly. So we could certainly start with that. Okay, I don't really have any side effects from that, but it's not helping me as much. Okay, let's increase it or let's back it down. It's not something that we'll have to change 4 to 6 months from now, because that's really when, that your testosterone pellet would wear off. And we see a lot of the times you can have those really, really high levels with the pellet. So that's not my, it's certainly my go-to. Yeah.
It's actually very encouraging to know that all these options are for women, because it seems like you have to be resigned to these changes in your lives, or your libido, or other physical things that we do have options.
Yes.
There was a question someone had asked in my social media, like, what kind of side effects can we expect? I think this comes from someone who's probably going to be starting hormone therapy soon. Are there any side effects that someone might notice if they start on estrogen, progesterone? We'll assume those two first, not necessarily testosterone.
Right. So sometimes you could have some nausea, from starting, especially if you're doing it orally. You may have, especially if the dose is a little bit too high, you can have some breast swelling or breast tenderness. One thing that I inform my patients to look out for, especially if you're postmenopausal, you really have not had that bleeding for more than a year. The estrogen is really kind of waking up those tissues. So you may have some vaginal bleeding, which could certainly be alarming if you're not used to it. And if you're not expecting it, rather. And certainly within the first 6 months of starting that hormone therapy, we know it's really just due to the hormone therapy. So you don't really have to have much of an investigation for that. But at any other point, any postmenopausal bleeding should really be looked at and evaluated to see, to see what's going on there. But those are probably the biggest ones. Would be the vaginal bleeding, the nausea, the breast tenderness. Sometimes you can have headaches, and for the headaches, I like to know about that as well, because if the dose is too high or if something else is going on, I would want to know about that as well.
Okay, that would probably go in the, someone had asked, how often do you adjust? How do you know if your dosage is too high or too low? So it's noticing those physical changes upon starting the hormone therapy.
Yeah, so that might be a way that you would, certainly know if it's too high, and you're following up, you're following up as well. Yeah, so we want to know, because we really base this on symptoms. You can certainly do blood work, but blood work is not always indicate or needed, especially in that perimenopausal time, because it's going, your hormones are changing rapidly, going up and down often. So blood work may not help us as much, but it's really your symptoms. Are you getting relief of the symptoms when we start that? Then we know, okay, it's working.
Okay, that's fantastic.
Yeah.
And then in terms of how one takes the hormone therapy, I think you've alluded to it, but to describe it, I think the one that I have is like patch and pill. Yeah. But if you can describe for people who are unaware.
Yeah, so the estrogen therapy, you can do it by the transdermal is what we like the best, because you don't have that increased risk of those of clotting. So you don't have that increased clotting risk or the increased risk of DVTs or deep vein thrombosis, things like that. So the transdermal is through the skin, because you bypass what's called the first pass through the liver, right? So you're not taking it orally, it's not getting processed in the liver, which is great. So transdermal is through the skin, and that would be a patch, and the patch can be twice a week or weekly, really depending on your lifestyle. If you have a hard time kind of remembering, we could certainly start with that weekly. But I sometimes find that by the end of the week, your symptoms might be coming back because the dose is kind of wearing off. The patch may be coming off. So then we'll do the twice a week. But patch is certainly a great way to start. You can certainly have a gel as well. The gel you would apply every day. There's also a mist, so it's almost like a spray. A mist, you would just use one pump, you would spray to your arm, and those are the transdermal forms. You could certainly do oral, which is what we spoke about before, but oral increases that clotting risk, so we don't like to start that way. But certainly if a woman, if she's not absorbing well through the skin, she doesn't have increased risk for clotting, then that might be a way to start. Additionally, you can use what's called a vaginal ring. So they have two types of rings. One that's what's called systemic, or it goes throughout your body, so it can help with those systemic symptoms, right? Like the joint pain or the hot flashes, the night sweats, those sorts of things, symptoms throughout your body. It can help with that. But they also have local therapy where you can use a vaginal cream, and this is just for the genital urinary syndrome of menopause or the vaginal atrophy. The increase, if you're having the increase in UTIs, it can help with that as well. That would be a cream or a small tablet that you would insert, and there's a ring for that as well. So you have all of those options, which are great in terms of the estrogen therapy. For progesterone, we like to also use what's called a bioidentical progesterone. So both of them, for estrogen and for progesterone, because they're similar to what your ovaries make. And the bioidentical progesterone would be a pill. You would take that every night because it helps with sleep as well, which is great. And progesterone as a hormone or a molecule, it's a very big molecule, so it's not absorbed well through the skin. So I know that I've seen on Instagram, you can probably even get it on Amazon. They have these creams, progesterone creams that you would rub on your skin, but it's not being well absorbed. So I truly don't recommend that if you're taking progesterone for that endometrial protection to oppose that estrogen. You're not getting that great opposition there. But progesterone would be a pill. They have the bioidentical. You can also do what's called synthetic ones, which would be similar to the one that they used in that WHI study, but we can have that increased risk of breast cancer and things like that with that. Although small, it can be slightly increased, but they really haven't seen those findings with the with the micronized progesterone, which is the bioidentical one. Additionally, you can also use an IUD, right? You can use a Mirena IUD, which is great to use. Especially in that perimenopausal period when your periods can be very erratic, when they can be extremely heavy. Mirena IUD or progesterone IUD is helpful to use in that, in that case. And we talked about the testosterone, the cream.
Yeah,
would be great for that.
Yeah. I think this will be, if someone is on birth control, how would they know that they would probably never need hormone therapy if they're not getting symptoms? Or I guess my question is,
yeah. So on birth control, it is safe, especially if you have no contraindications. You can continue your oral contraceptive pill or your combined pill if it has that estrogen and progesterone until about age 55. You can certainly safely continue it until then. But when we stop it at that time, if your symptoms come back, then we really recommend that you use that menopausal hormone therapy because it's a decreased dose, less risk. So that's really when we do the changeover. But yeah, you may not have symptoms until we stop it at 55. And then you're like, oh, okay.
Oh, that's so interesting. Oh, that's great to know.
Now. Yeah.
Okay, great. And then my last question is there anything else, just I guess as a practitioner, that you want people to know about hormone therapy that we might not have covered?
Well, in terms of the testosterone therapy, when we were talking about that before, unfortunately, there is no FDA approved testosterone for women, at least in this country. Yeah. So certainly when you get that, which is crazy. I know. I think we're working on it, hopefully sooner rather than later, but currently there's no FDA approved, testosterone for women. So what we have to do, generally we use a dose, that's indicated for men, and the testosterone for women is usually 1/10 of the dose. So something that a male would use for one day, we just kind of spread it out over 10 days, right? But often this is something that we may need to compound, which is certainly fine because sometimes the compounding pharmacies also get a bad rap. But I think if you have a great pharmacy that does third-party testing, that's a great place to kind of compound this when you need that testosterone therapy for that decreased desire, right? But additionally, in terms of my recommendations for women, is that you don't have to suffer. There, as we covered today, there's so many different options in terms of estrogen, progesterone, testosterone, even to cover the array of symptoms, the up to 50 symptoms that you can have during this menopausal transition. You don't have to suffer. I really recommend, though, especially where it's great that we're seeing a boom in terms of discussion of menopause on Instagram or any of the social media, but you really recommend that you see someone who's really trained in this, seeing a menopausal specialist, because that's someone who can really sit down with you, take the time, understand the research, and go through your risk, your benefit, really knowing the optimal time to start, the different routes to start, which way, what would be best for you. I think it's really important to have that conversation. Even if you think you may be at increased risk, still have the conversation, because you may not be able to take hormone therapy, but what can I take? You don't have to suffer. There are treatment options out there.
You just made me think of my very last question, because there's so many benefits. Once you're on it, do you ever have to stop it if it's working for you?
Yeah, that's a great question. So the Menopause Society and the ACOG, as well, the American College of OBGYN, they say no, you certainly don't have to stop it if it's working for you. So before, it used to be age 60, 65 is really when they recommend that you stop it. But you don't have to. But it is important to reassess your risk, right? So if your risk is increasing, then you may want to decrease it or at least stop it and look for other, other options to help with those symptoms. But it is really important to follow up with your healthcare provider, often kind of reevaluate those risks, I would say at least yearly, and see if it's still recommended for you. But as a blanket statement, does everyone have to stop it? No. I have patients in, their 70s who they're still on it. Yeah.
Oh, this is so helpful. Dr. Dineasha, thank you so much for clarifying a lot of some of the, I guess, myths or questions we've had about the new hot thing, hormone therapy. I look forward to you coming back another time when I think of another good subject to ask you
Tina,
questions about.
I love to be here, so that's, I'm looking forward to that as well. Yeah.
Thank you.
You're very welcome. Thanks you.
I'm Coach Tina. For more information about how to work with me, head to ironstrongfitness.com and send me a message. I'll see you next time.